leading causes of mortality in children. About 4% of pediatric patients who are admitted into the hospital are admitted with sepsis, and about 8% of patients who are admitted onto PICU have sepsis. Mortality rates are quite variable, going from 4 to 50%. And if we think about on PICU, the normal mortality rates are about 4 to 5%. That's quite a bit higher. And these mortality is due to refractory shock, plus or minus multi-organ dysfunction. And the majority of these deaths happen in the first 48 to 72 hours. So the Surviving Sepsis campaign was set up as a consensus group looking at evidence-based guidelines. It was set up in 2001 and comes out with recommendations about every 4 years. They review all the evidence and reassess their recommendations at that point in time. It's a multidisciplinary group from all over the world looking at the latest guidelines and making recommendations. The first recommendations came out in 2004, and the latest recommendations came out in 2020. And I'm going to be basing my talk really on those recommendations from 2020 because it changes a little bit of the way we do things. So in terms of the definition in children, which are a bit different to adults, severe sepsis is defined as 2 or more age-based SIRS response criteria. And they are, SIRS criteria, as I'm sure you know, are looking at core temperature, whether there's hypo or hyperthermia, looking at leukocyte count, whether the white count is high or low, heart rate, inappropriate tachycardia or bradycardia, systemic blood pressure, and respiratory rate. As part of this, there's also confirmed or suspected invasive infection, cardiovascular dysfunction, acute respiratory distress syndrome, and in the first time here, they're now looking at non-cardiovascular organ dysfunction as part of their definition. Septic shock is a subset of this with cardiovascular dysfunction, which includes hypotension, impaired perfusion, and the need for treatment with vasoactive medication. And sepsis-associated organ dysfunction is severe infection, which leads to cardiovascular and or non-cardiovascular organ dysfunction. Fluid refractory shock is generally considered to be shock that persists after 60 mils per kilo of fluid that's given over a short period of time. So not that's given over 7, 8, 12 hours. Vasoactive resistant shock is shock that persists, not unsurprisingly, despite giving adrenaline and noradrenaline. And clinically, in the past, warm shock has been defined, as we know, as the patient who comes in vasodilated. They have low systemic vascular resistance, high cardiac output. They have flash capillary refill times of less than a minute, quite bounding pulses, warm extremities. They can often look quite red, slightly plethoric. And we see that they've got decreased diastolic blood pressure and generally a wide pulse pressure of over 40 millimeters of mercury. In cold shock, we have the opposite. We've got high systemic vascular resistance, low cardiac output, cold extremities, prolonged capillary refill time, weak pulses. The diastolic may be normal or low or increased, and the pulse pressure tends to be low. And we'll go back to what this actually means and when we're using what, because traditionally we've used noradrenaline in warm shock and cold adrenaline and adrenaline in cold shock, but actually it's we need to look at our ability to really define these and to be able to with certainty say if we're in one or the other. In terms of the pathogens and sites of infection, in quite a large percentage of cases in the United States, no pathogen was found, in between 35 and 57%. Now, it's not clear as to why that was the case if early cultures had been taken. Gram-negative and gram-positive were between 12 and 28, 30%. For both of those, I was surprised to see a rate of fungal infections between 4 and 13%, and viral between 11 and 21. As we can expect, the sites for these infections, respiratory quite often, between 9 and 57%. Primary bacteremia, as we see with meningococcal sepsis or pneumococcal sepsis, 19 to 68, some abdominal, a bit of CNS and genitourinary, and occasionally in skin. Oops, sorry, that's not what I want, not quite where I wanted to go with this. But in terms of treatment, we'll just go a little bit through the guidelines and what we normally treat patients with and how things have changed or what the recommendations are. And we'll start with sodium bicarbonate. There isn't any discussion in the guidelines of giving sodium bicarbonate. I personally use it when we have severe acidosis and inotropic requirements, and titrate it to the base deficit, doing half corrections and looking at the numbers, because our feeling is that when we're giving inotropic support, that if we are less acidotic, our inotropes have a better chance of working. But it wasn't mentioned at all that there are about 77 recommendations in the guideline, and they touched on most things, but sodium bicarbonate was not one of them. Going back perhaps to the beginning, they talked about screening and early recognition of sepsis. We're all familiar with pediatric sepsis 6. They also thought that those places that had electronic systems actually probably did a little bit better at recognizing and picking up sepsis early. And this sepsis 6 is what we see all over the place in our EDs, and what we need to think through in terms of looking for those SIRS criteria of temperature, tachycardia, GCS, perfusion, and blood pressure comes at the very bottom of those things. Thinking about giving oxygen, getting IV access, which we'll talk about a little later, and giving antibiotics, early fluid resuscitation, and quite aggressive, as well as early inotropic support. They looked at lactates, and I think in adults, lactates can be used for stratifying risks of septic shock, but not so in children. It is a very useful bit of information because it's a useful surrogate for tissue perfusion and hypoxia. High levels are associated with adverse outcomes when you've got hypertension needing vasopressors. If your lactate was over 2, studies show that your mortality rate was 32%. If your lactate was less than 2 and you needed and you were hypertensive and needed vasopressors, your mortality halved to about 16%. If you can manage to normalize somebody's lactate within the first 2 to 4 hours, it's been noted that you have a decrease in persistence of organ dysfunction, and your patients just generally do better. In terms of fluids, we've now gone to 10 ml per kilo fluid boluses and reassessing. It's important that we give enough fluids, especially in the very beginning, and we talk about typically 40 to 60 ml per kilo within the first hour, titrated to a response, obviously, but also looking for signs of fluid overload. Those signs are not as easy to see as they are in the older adult patient. You're less likely to get growls when you examine their chests. You may see an increased liver size, but it would be probably important to have assessed what the size of the liver was before you started out, to be able to see if it does increase. But you may have to at some point think about slowing down your fluids and starting your inotropes early if you have fluid overload. In terms of what fluid to use, buffered crystalloids should be used instead of normal saline. So Ringer's lactate, buffered Ringer's lactate, or plasma light. Normal saline, especially in 40 to 60 mils per kilo, you get really high chloride load, which is associated with systemic inflammation, worsening AKI, hyperchloremic acidosis in an already acidotic patient, increasing coagulopathy, and at the end of the day, increasing mortality. So if we can decrease the amount of chloride that we're giving our patients, we may help avoid a few of these problems, or at least lessen them. In terms of intubating patients, and RSIs. I know you had to talk earlier about airway management. Preparation is absolutely key for these unstable patients. A pre-brief, I do a pre-brief with a team as part of the RSI checklist, but also to make sure that everybody has got the same mental model of what's going on, that we're prepared in terms of what could go wrong, and if so, who's going to do what, that we have all of our drugs that we could possibly need available to us, and that we are really organized. Have additional fluids at the ready. You may need to give small or larger aliquots as you go along. Consider starting, if your patient is unstable, vasoactive agents before intubating, such that your adrenaline, your peripheral adrenaline, is already on board. If you don't have central or IO access, you can think about using metronidazole if people are comfortable with that drug, and often the anaesthetists are. On PICU, we often use dilute adrenaline, 1 in 100,000, affectionately known as a spritzer, and we just give small 1 ml aliquots to help support the blood pressure if it's starting to sag. But having those running beforehand and actually having reached the patient beforehand, I think, is really important and may smooth out that induction period and that first part of intubation for the patient. In terms of what drugs to use, I would strongly suggest using ketamine. You're already in a quite stressful situation with a very sick patient in front of you, and therefore ketamine is going to be the most cardiovascularly stable agent that you can use. It isn't perfect, and it's not absolute in its stability, but it may get you through a rough time. I would advocate not using propofol or not adding bits of midazolam in, because you may find you've lost all cardiac output at the end of that syringe. We talked about warm versus cold shock earlier, and the guidelines look at clinical assessment alone and say that clinical assessment alone may make it difficult to actually differentiate between the two. You would think that they look quite barn door in their description, but ideally they suggest having more advanced monitoring in terms of advanced cardiac output monitoring, cardiac index or cardiac indices, systemic vascular resistance monitoring, as well, or oxygen saturation monitoring, venous oxygen saturation, and mixed venous saturation monitoring as well. Calcium, not strong recommendations, but I think most of us try to maintain an ionized calcium above 1 or 1.1. We know that in children, about 75% of pediatric patients with severe sepsis are hypocalcemic, and therefore replacing that calcium makes sense. It will help their myocardial contractility. It will help their systemic vascular resistance as well. So useful things to do. It will also, it will increase your blood pressure through those two medias. Hydrocortisone. They weren't, the consensus guidelines talked about it only being used really if adequate fluid resuscitations and inotropic supports didn't do the trick. It could be helpful in, again, helping your calcium availability, changing your decreasing your reuptake of noradrenaline, so making it therefore more available to your receptors, and again helping your vascular resistance. It decreases your endogenous nitric oxide production, and therefore by decreasing that, decreases your vasodilatation. The suggested doses are standard 1 milligram per kilo every 6 to 8 hourly. Blood products, I think we use them quite liberally, and maybe we need to think again. Their recommendations that were that if your patient was stable, not to transfuse if your hemoglobin was above 70. The recommendations for an unstable patient are much less clear. The general tendency, I think, would be to maintain an HB of 100 in a patient who's not stable. For platelets and FFP, they suggested not giving them prophylactically just based on the counts or just based on your coagulation numbers if there weren't any signs of bleeding. Obviously, if you have a bleeding patient, that's a different story, and they would then recommend giving it in those situations. Now, down to the vasoactive section of this. Adrenaline and noradrenaline, we've gone away from using dopamine. I think dopamine was used very liberally before because people were relatively comfortable with it, because they were also happy with giving it peripherally. We're now really moving towards using adrenaline and noradrenaline in those early stages. They can both be given peripherally. They can obviously be given through an IO needle or centrally. They just need to be diluted appropriately for adrenaline and noradrenaline to be given over a short period of time through a peripheral cannula. And obviously, the bigger the cannula, the better. The starting doses are between 0.05 for both of those, a starting dose going up to 0.5 or 1 roughly. Vasopressin is used centrally and is added in when you already have high dose catecholamine. There isn't actually a recommendation for you need to start it when your adrenaline gets to 0.4 or 0.3 or your noradrenaline gets to whatever number. I think it's just people's feeling about where they're at, how effective their inotropes are, and when they want to start it. So it's a little bit, it's going to be each clinician is going to make a decision on when they want to start vasopressin. I think you need to think about it early because it is it's not something that we make up on a regular basis, and it takes a little while to get your head around how it's made up and how you work out the units and the dosing. So if you think about it early, that is a really helpful thing to do, because it'll give people time, if they don't do it on a day in, day out basis, to go through it and double check it and make sure that they are happy. IV access. Obviously, we try to get peripheral access when a patient comes through ED or is seen on the ward, but as I'm sure you all know and you all do, you try to gain IO access if your first attempt or two at peripheral access is unsuccessful. But I think it's also really important to think about where we're putting IO needles. I think APLS, previously we were focusing on tibial areas for IO needles, and I think especially in the smaller patients we really need to think about the femoral placement of IO needles or humeral. I think in the smaller patient the femoral area is much better. It's much more stable. You're much more likely to have success and not have to redo things or have things tissue. So that is what I would advocate. Get help placing your central access. You may have an anaesthetist, if you're not in an area that has a PICU, who is really happy to do so, especially in the smaller patient. They can be challenging. Think about trying to access the neck, which is just going to be an internal jugular, is going to be easier because it's a bigger vessel in general. In terms of transport, again, it's about being prepared, making sure that there is a shared mental model within the team, both the local team who are referring the patient, but also the transport team. Have additional fluid boluses drawn up, have calcium drawn up if the calcium levels are tending towards the lower side. Have additional vasoactive agents made and attached if you're on adrenaline, but you're on a decent dose already and you think I probably need to add some noradrenaline in, have it made up in your pumps and attached to your patient, and then all you have to do is press go. In terms of some really practical points that people don't always think about, and if the team that you're arriving at doesn't have a PICU nurse or an ICU nurse on with them, they may not think about if somebody is kindly and really deftly put a central line in, and you've got a triple lumen, there might be one inotrope on one lumen and another inotrope on another. And think about putting some splitters in such that you can put all of your inotropes. You might have, adrenaline, noradrenaline, and vasopressin, and they can all go on a splitter on a lumen. So you're just dedicating that one lumen, but you're leaving everything else free for other things that you need to give. It means that you're not having to interrupt things and putting it on to and interrupt your vasoactive agents and having to put it onto one line somewhere in the middle when you already have a patient who's unstable, and that brief swap over may make things even worse, or you're having to piggyback and just take time. The other practical thing that people don't always realize is, and it depends on what pumps you use. If you're using the bigger Alaris pumps, they deal with pressure, and they've got pressure discs on them. And as you're moving them about, you may end up actually giving a bolus or having a slight decrease in for a very short period of time, of the delivery of your vasoactive agent. So if you are moving your pump from the bottom of a trolley, for example, and then moving it up onto the bed, the resistance goes down because you're no longer having to pump uphill, and you'll see that your patient's blood pressure may go up a little bit because they're actually getting an effective little bolus for a short period of time. And the same thing if you're going from a pump on a bed and then moving it to the bottom of your trolley. You really need to do that in a slow fashion and just take time and just inch it down such that it has time to catch up with itself, because you may have a little period of time where it's not managed to catch up from a pressure delivery point of view and give you that your constant amount of vasoactive agents. You might see, if your patient's really very sensitive, you may see your blood pressure dip. And if you're kind of on the cusp, that may be enough to really destabilize your patient. Another thing to talk about is windows of opportunity. It's when do you go? How stable does your patient have to be? And I think those are a really difficult thing to know. And actually, can you go? And I think it needs really very frank discussion with the referring team and with the families about how stable a patient is, what are the risks of moving. Is it that you're moving to the child's definitive care, and it may be a surgeon, for example, or there's a foreign body that needs removing? I had a child with a K-wire in once that became infected, and actually by the surgeon locally removing that K-wire, we actually had a degree of we managed it from reality after having put the patient on adrenaline, noradrenaline, and vasopressin. But it gave us that window of opportunity to go. But sometimes those opportunities actually aren't there. And so I think we have to have a long and hard think about, can we actually move this patient at all? And we have to be really very, very open with the parents about what the risks are when we do so, and make sure that they are aware and as happy as one can be with those risks. Fewer ambulances. So in summary, these are evolving guidelines. The feeling is that more RCTs are needed to fill in some of the gaps in knowledge. Lots of things where practically people did give calcium or blood or hydrocortisone, but the evidence for it wasn't that great. Importance of early recognition, antibiotics, IV fluids, and early inotropic support. The management of these children doesn't just mirror the management of adult sepsis, in that their comorbidities are different, their reactions and the host reaction is different than they are in adults, and so we can't just take things lock stock from one to the next. We need to anticipate and have things ready at all times to make things go as smoothly as we possibly can from a transport point of view, and as well as just from an initial stabilization point of view. And thank you. Are there any questions?
So, Dr. Raja, we had a couple of questions in the chat. The first one was, can you clarify the doses of adrenaline and noradrenaline? And I think Ryan Perry has put a very good up-to-date .com image key where he talks about all the vasopressins that are available. The second question was regarding the calcium replacement and the doses. Any advice from you at all?
So we tend to give calcium gluconate, that's probably what's easiest, 10%. You can give 0.5 mils per kilo of calcium gluconate. And then you're checking, we tend to look on the gas because you look at the ionized calcium and just keep rechecking it and see what the direction of travel is for that.
Lovely, thank you. Another question that has come up is regarding coagulation. So would you correct a prolonged PT with vitamin K?
I guess you probably don't come to any harm from doing it. I think, and it'll just be the standard BNF doses of vitamin K per kilo. The recommendations, again, if your patient isn't bleeding, isn't to just correct the numbers, but really look at what your patient is doing.
Fair enough, thank you. There's another question regarding hydrocortisone. So at what point do you reach for hydrocortisone? Would it be early shock or would it be refractory? And when would you be starting it with regard to inotropes?
So refractory, I think, because the evidence is that it has side effects in terms of hyperglycemia, and I've not gone into glucose management, but and I think they're not the most major effects, and I think the beneficial effects of hydrocortisone in terms of sepsis, in my mind, outweighs the other problems that you can have with it. I would give it in refractory to one inotrope. When you're starting to add in another one, I think you have to think that your hydrocortisone isn't going to be an instant fix, so it's going to take some time to work. So you want to think about it early. Would be my suggestion. I think if you're getting to 0.2 or 0.3 of adrenaline, you're thinking about, or noradrenaline, you're thinking about adding other inotropes in, I'd certainly be giving hydrocortisone at that point in time.
Thank you. The last question we have here is regarding doses of adrenaline and noradrenaline again, because the link that was given by Ryan is for the adult doses. So there was just a clarification whether the pediatric doses are the same.
Starting doses are 0.05 to 0.1 are a starting dose. I think you have to think of how long it's going to take to get to your patient. In obviously a peripheral dose will get, because it's more dilute, will reach a patient a bit sooner than if you're doing a more concentrated central access dose. And then you just need to titrate to effect. You have to start out with something. Sometimes I start out with a bit bigger of a dose when I know it's going to take a while to actually get to the end of that lumen. You need to prime your lumens. You need to prime your infusion as much as possible, so it's good to get to your patient as soon as possible. I'm not sure. Does that answer your question?
Yes, I think it does. And there is also a couple more questions that have now come out. And one of them is actually a very good suggestion, which talks about retrieval charts that are there for cats and for STRS, yes, where there is the pre-filled drug charts. All you need is the child's weight.
Yes.
The second question is regarding access. So frequently I'll walk into a peri-arrest scenario where there have been many attempts at IV and nobody's tried an IO. What is your threshold, and how many, in your opinion, is too many?
I think if people have had 2 goes, they should probably, in that type of child, certainly I think in the peri-arrest, you might as well just go for an IO straight on, really, unless somebody can really sling a cannula in very quickly. I think, I think people can you can see people becoming focused on a task and not actually taking in the more the general situation, and that's, I guess, where your team leader really comes in to direct people to say, you've had a go or two, you need to get IO access now.
Thank you. Any thoughts on EJV as an access in infants? External jugular venous access.
Yes. Yeah. Yes. It may be your easiest vein in the first instance. Absolutely. It's a big vein. It's a good one. It can get you out of bother in the first instance while you're trying to get more central access. Definitely. I don't think external jugulars are used in this country. They're used in developing countries an awful lot, and you'll see people are really, really slick at getting them in. I think they can be a little bit tricky in the infant who doesn't have much of a neck, but somebody who's really adept at it, absolutely.
Fair enough. Thank you. I mean, that was a wonderful presentation regarding the new kind of changes compared to 2004 guidelines, which we are all very familiar with, to what was the new update in 2020. And as an adult emergency physician myself, I think I learned a couple of main differences about, the pediatric ones. So thank